everybody. I'm hoping you're having a wonderful evening. I'm Melinda Pettigrew. I'm the Dean of the University of Minnesota School of Public Health, and it's an absolute pleasure to welcome you here today. Thank you for joining us for the David J. Fine Distinguished Visiting Professor in Healthcare Administration Speaker Series. So, as you all are aware, we are living through a particularly challenging time here in Minnesota, and the opportunity to gather here in person feels really important. We have a shared purpose today, and I'm just really so pleased that we could be here in person. It feels really important and necessary at this moment. Before we begin our program, I'd also like to start by acknowledging that the School of Public Health at the University of Minnesota Twin Cities is built within the traditional homelands of the Dakota people. Minnesota comes from the Dakota name for this region, Minnesota Makoche, which loosely translates to the land where the waters reflect the skies. It's important to acknowledge the peoples whose land we live on, learn, and work as we seek to improve and strengthen our relationships with our tribal nations. We also have to acknowledge that words are not enough. We must ensure that our institution provides support, resources, and programs that increase access to all aspects of higher education for our American Indian students, staff, faculty, and community members. For more than 80 years, the University of Minnesota School of Public Health has educated influential leaders in public health and healthcare with a lasting global impact across the globe. Our community contains over 12,800 alumni, nearly 130 faculty, and close to 1,000 students. This is a source of great pride for me, and I think for all of us, and especially our Master of Healthcare Administration program. For more than 7 decades, the MHA program has prepared leaders across the healthcare industry, including many who are here with us today. It's alumni like you who continue to elevate and support the School of Public Health in so many meaningful ways. As Dean, I am deeply, deeply grateful to the MHA alumnus, Dr. David Fine and his wife, Susan, for their philanthropic generosity, which has made this wonderful lecture possible. The David J. Fine Distinguished Visiting Professor in Healthcare Administration lecture brings a nationally recognized academic and thought leader to campus each year to deliver a public health lecture and engage with students, faculty, alumni, and broader university community. Thank you so much for joining us this evening to learn and grow together. A special thank you to Dr. Victor Montori, who I've been hearing has had a wonderful visit thus far, especially with the students. Dr. Victor Montori is our 2026 David J. Fine Visiting Professor, and we really want to thank you for sharing your expertise with this community. Now, please join me in welcoming Dr. Jean Abraham. She is a division head for health policy and management, and she will talk to us a little bit more. Thank you.
Good evening, everyone, and thank you, Dean Pettigrew. Without the generosity of MHA alumnus David J. Fine, class of 1974, and his wife, Susan Fine, we would not be able to have this incredible opportunity to share a prominent scholar and healthcare leader like Dr. Victor Montori with our students, alumni, the university community, and Minnesota industry leaders. For 40 years, David had an incredibly successful career as a healthcare executive and university faculty member, bridging practice, education, and academic leadership roles across the country. It has been a privilege to engage with David over the past several years to learn about his career, his leadership, and the impact he has had on so many students and young healthcare leaders. Through our conversations, I know that David is passionate about education and the value of lifelong learning. The generous gift that David and Susan have provided to establish this Visiting Professor series is a testament to that. Please join me in thanking Dr. David Fine and Susan for their generosity and enduring support with a round of applause. So at this time, I would like to turn things over to Dr. Bjorn Berg, Interim MHA Program Director.
Good evening, everyone. Thank you, Jean. So I'm delighted to welcome and introduce you this year's David J. Fine Visiting Professor, Dr. Victor Montori. Dr. Victor Montori is the Robert H. and Susan M. Rewoldt Professor of Endocrinology at Mayo Clinic. He is a consultant in the Division of Endocrinology, Diabetes, Metabolism, and Nutrition, and holds a joint appointment in the Division of Healthcare Policy and Research. He's the founder and director of the Knowledge and Evaluation Research Unit at Mayo Clinic, which fosters interdisciplinary collaboration to advance person-centered care for patients with chronic conditions. Dr. Montori's research in the field of healthcare delivery is informed by his extensive training in medical research and his frontline experience as a practicing endocrinologist. Using innovative patient-centered methods, he studies how to make care fit the lives of patients, ensuring that the burden of treatment does not overwhelm those living with chronic illness. He is a globally recognized expert in evidence-based medicine, shared decision-making, and minimally disruptive medicine. His research program is built around the central challenges in healthcare, where the industrialization of care and the need to move from a system of greed and speed to one of genuine human connection. His work suggests that careful and kind care and a radical shift toward a patient revolution are the critical factors for creating a high-performing and compassionate healthcare delivery system. It's been a real pleasure to have Dr. Montori here as the David J. Fine Visiting Professor among our faculty, staff, and students during these few days. He's joined us from just down the road at Mayo Clinic in Rochester, and we are so thankful to have this event when his characterization of care and its artificial future feels especially resonant. His visiting professorship time is quite busy, and today was full of meetings with faculty, lunch with doctoral students, and an afternoon with MHA students and alumni. Tomorrow's schedule includes more time meeting with faculty, a research seminar titled Investigating at the Point of Care, and a moderated panel titled What the World Needs Now, Care as a Vision, Resistance, and Hope. Now, please join me in giving Dr. Victor Montori a warm University of Minnesota welcome.
Wow, this is pretty scary. I am very grateful to Dr. Fine and Susan Fine for creating this professorship and for the faculty of the department for selecting me for this honor. Particularly at this time. I think it's important to declare that I have no financial conflicts of interest. I am a salaried clinician at the Mayo Clinic. I develop work at the Care Unit, which has not, since inception, received any funding from any for-profit corporation. And I am the founder and chair of the board of the Patient Revolution, which is a volunteer organization. I don't derive any income. In the back, there is a table with books that is available for you. I don't derive any income from that, but I'm happy to sign the cover of it. And I signed the cover so that if you put it on eBay, I know who it is. I once found one that said, to Tim, in recognition of our lifelong friendship and collaboration, and it was for $2.50 on eBay. This is Derek. So Derek made the news because at Mayo Clinic, he received a face transplant. Face transplant that took many, many months of planning, multiple surgical teams, 2 days of operations. 10 years prior, Derek had tried to end his life and had essentially injured severely his face and had experienced a number of different operations to try to make his face work. but not being very successful at it until he was eligible for and pursued this face transplant. Mayo made a big deal of this, as you would, and the press got to chat with Derek, and somebody asked him, "What are you going to do now with your new face?" And Derek said, "Well, I will hopefully find a partner, fall in love, make a family, and then I'm going to dedicate my life to prevent the kind of thing that I had, and I'm going to dedicate my life to take care of people with mental illness." And it's actually really interesting because this feat of surgery, with all the surgeons and the team and everything, it deserves our attention, our press, and our celebration. But the quiet work of helping everyday patients with chronic conditions like mental health conditions doesn't get much attention, doesn't get like this kind of celebration, which in fact is celebrating the failure, if I may, of such a system. Now, places like the Mayo Clinic, but many other healthcare organizations, when they look at how they respond to the problematic situation of people, they really are doing one of two things. They're either trying to cure or fix people, or they're trying to care for people. On the cure side, the challenge seems to be, how do we make the right diagnosis on the right patient the first time, make sure that they get the right treatment by the right team, done perfectly the first time. It's a pursuit of perfection. We have the right equipment, and we have the right expertise, and we make this happen. And we celebrate that. That activity is very, very important, but there's this other side. Notice that this line doesn't go all the way to the corner of my slide, because at any point, you have to have both. So I'm not putting them as opposite. But on the care side, the tasks are a little different. You know, we need to manage symptoms, mitigate harms, cope with disappointment. I think disappointment is the most common outcome for my patients when they see me. Prevent complications, rehabilitate sequela, support self-management, problem solving, make care fit. With cures, we want perfection. With care, we want care that fits the life of the people that we have. I'm going to focus for this conversation on the care side of this slide. And the reason is the epidemiology teaches us that we are experiencing a surge in multimorbidity, in chronic ongoing conditions that we cannot fix, that we cannot cure, that people have to live with while they're living their lives. And you can pick from the literature, there are graphs like this from almost every middle income or high income country. And you can see on the x-axis is age distribution, y-axis is the proportion of patients. And this is a known thing. The older you get, the more chronic conditions you have. But what's striking about this figure that looks like a wave is that it's moving left. In other words, increasingly people who are younger are experiencing life with chronic conditions. Also notice that if you follow the 50% mark, so looking at the average person, you look at the middle-age mark, and essentially the average middle-aged person now is no longer a healthy person. It's somebody who lives with at least one chronic condition. So if you are an MHA student and you're designing healthcare delivery services, the person you have to imagine is not a healthy person. The person you have to imagine is someone who's going to show up with at least one, if not more, chronic conditions. Also, as this moves left, what's happening is that the accumulation of those chronic conditions is occurring faster in people with more disadvantage. So if you're actually setting up service for people with disadvantage, the age at which you're going to see multimorbidity will be younger, and most of the multimorbidity will be, like Derek's, a mental illness. So how might we respond to the problematic situation of patients that present with multiple chronic conditions? And this is Maria Luisa, who has been with me on these presentations for over a decade. And this is a picture taken by her granddaughter. She's at her home, and you can see her looking down at her mountain of pills that she has to take to keep her health. And as you appreciate her expression, you understand that Maria Luisa looks lonely, tired, overwhelmed. I think it will be hard to say, oh, she looks healthy. How is it that she ends up with all those tablets? In part because in healthcare, as we are processing people, we begin to look for diagnostic labels, what she has in common with other people like her, and we actually respond to that, respond to what's wrong with her biology. And in responding to what's wrong with her biology, we say, oh, there's diabetes, okay, where are the guidelines? Okay, this is the box for diabetes, I'm gonna deliver diabetes care. Oh, she has hypertension. I look for the hypertension box, okay, this is the evidence-based hypertension algorithm, and deliver the hypertension care. But if you have 6, 7, 8 conditions, you end up with 12, 15 different medicines, each for one for each of these conditions. And the problem with that is that you are now not caring for Maria Luisa, but you're caring for what she has in common with other people. You're caring for people like Maria Luisa. But that's not the job. The job is to care for Maria Luisa, and that requires us that we go beyond what she has in common with other people, what's wrong with her biology, to actually understand what's up with her biography. Where does she come from? What's her story? How that she ended up in this situation? And not only in terms of needs and challenges, but also in terms of the things that you can mobilize as strengths to make a difference in her life. How is her life now? How are treatments interfering with the life she wants to have? And how are treatments enabling the life she wants to have? And how is the routines of her life interfering with the ability that she has to access and use those treatments? And then looking forward, what are her goals and priorities for her life? And how aligned is her treatment plan with those goals and priorities? Without appreciating the biographical elements of Maria Luisa's story, our treatment is generic and accumulates to the point that is difficult to implement. Another thing that we have gone into healthcare now in doing is there's a lot of things that we've decided that patients and families are better at doing than we are. And we've improved our efficiency by transferring work to patients and families. When we do that, we are imagining the healthy person that comes in for one problem one time, and yeah, for them to fill another form, no big deal. But for patients with chronic conditions that keep coming back, through multiple doors to see multiple different people all the time, this work accumulates. For people like Maria Luisa, we might expect that she needs to come in with organized information, ask prioritized questions, review the medical record, use the portal, the apps, share data from her wearables, self-monitor, self-manage, educate herself, manage appointments, prescriptions, bills, pre-authorization, denials, delays, overcome whatever biases she needs to do, keep everyone informed, advocate for herself, and of course we will ask her to wait. Wait for an appointment, wait for in the waiting room, wait in the doctor's office, wait for the clinician comes in, wait for the test to be done, wait for the test results to come in, wait for the treatment prescriptions to be filled, wait for the insurance company to authorize those pre-authorizations, wait. When they call in for information, our recordings should be changed to be more sincere. Thank you for calling. Your time is not important to us. Your call will be answered in the order in which it was received, because we are completely indifferent to the level of urgency with which you have called us. And in fact, this is you will see, it's an important element of our healthcare system, indifference. And when people cannot implement all the work that we're asking them to do, our response is to label them, not their situation, but their character, their lack of personal responsibility, with a label such as non-compliance or non-adherence or whatever sounds good for the day. A label that is very sticky, and when she gets to see another clinician, will see that label and understand that this person cannot be helped. And when you come for healthcare and you do not get the help that you need, that is fundamentally cruel. As it is the cruelty of indifference, in which people can come in, we welcome them with a wall. It could be a window, but it's a wall. In this case, this is a picture I stole from the internet where people stopped, got tired of waiting in line, so they put their shoes in line and they went and had a seat. But this indicates a level of indifference to the urgency of people. I'm tired, and not tired, but I guess my capacity for reaction to what's horrendous is like yours, probably completely overwhelmed. But story after story of a person, maybe a young woman of color that comes into the emergency room, pregnant with abdominal pain, asked to be seen, and she's told to wait, sit down and wait for your turn. only to be found, maybe an hour or two later, bleeding to death. Indifference is a form of cruelty. Cruelty should be a never event in healthcare. What I just described to you is something that I think we can consider as industrialized healthcare, where the processing of people has replaced what we think is care. The problem with this form of industrialization of healthcare is that it's unsustainable. It's unsustainable environmentally. Our healthcare hospitals should be centers for health, actually spew a significant proportion of greenhouse gases and carbon. They're financially unsustainable, and we hear it all the time. Oh, we can't afford all this healthcare. Now, I want to focus on the other form of sustainability, human sustainability. 40% of our workforce, of our clinicians, our professionals are burned out. They're having mental illness, they're quitting their jobs, they're cutting back on their clinical hours, they're not making themselves available to patients, they're working in unsafe conditions and putting their patients at risk. They're struggling with moral injury because they know what they ought to be doing and they can't do it. 40% of our patients with multiple chronic conditions are reporting being overwhelmed by the amount of work that patient is asking them to do. 40% of the time patients and clinicians are together, the clinician is completing documentation in the medical record, documenting care rather than caring, interrupting patients within 11 seconds of their answering the question, what can I do for you today? And so if you had to take one number home, 40% is the number that I think represents the crisis of care. So how might we respond to this crisis of care? One common answer, and many of you are going to see this in your practices, is to think that the crisis of care is to assume that it's a crisis of organization. It's a crisis of efficiency, of productivity, of convenience, of information technology, or of scale. And so much of the work gets to target these particular areas. But if you were to follow the logic, you will have to conclude that organizations will need to operate at scales of speed and reach that are only possible when you abandon the idea that care is only possible between people. And so you start finding ways of introducing bots, introducing all sorts of different things that will actually give you that ability to reach out and cover as many people as you can. And when you actually ask for more, that affects that sustainability in a negative way, because you're asking for more consumption of data, more consumption of medications, more technologies, and that ignores other priorities for your communities, for instance, education, and that ignores the priorities for our planet in terms of our ability of the planet to sustain human action. In healthcare, we've decided to emphasize this informational aspect. And I'm going to show you, just to focus a bit on this arch and see what you think. Early on, we had a documentation of what happened in the clinical encounter with paper records. They were kept in physician offices and in hospitals. They were stored on site. Usually, if information will flow, it will flow with letters, faxes, and usually these were hospital-owned and managed. Major limitations, but it was clear what the purpose was. The purpose was to support care here. Over time, electronic health records began to be disseminated. They, for the most part, were locally hosted, and they sort of reproduced, to some extent, the paper record structure and function, just made it electronic. And when that began to happen, additional uses of the record became more possible, including, for instance, extraction of business information that allow folks like many of you in the room to actually be able to study the business of healthcare and try to optimize its efficiency. From right above around the time of the Affordable Care Act, we had a mandate to actually have electronic health records. Significant investments were put in, and electronic health records were taken up significantly across the country, forcing a number of changes in the structural healthcare to be able to afford these systems. Eventually, over time, those systems have matured, have become cloud-based system, so no longer supported by local IT infrastructure. In fact, many IT departments have been shrinking as those companies have been able to add services to support these features. The issue of interoperability is still evolving, but it's a priority. Patient access is now mandated, so patients should be able to access all their record. And so we have portals to try to look at this, and there are now systems that allow you to extract from the different portals, from the different healthcare systems, so you can, as a patient, try to unify your medical record. You have self-management apps on your phone that you can use for your anxiety, your depression, your hypertension. You have devices, wearables that you communicate and interact with. And you have sensors now in hospital beds to determine if a patient, for instance, has urinated in the bed. You have sensors, so the nurses don't have to go in and check on you. There will be an alarm, and the nurse will be able to know that it's time to change your bedding. All these systems have now enabled us to understand the behaviors that people are having in and outside of the healthcare system, and begin to wonder if we can actually make inferences about how those behaviors are contributing to ill health. And this is something that the technology companies that are now partnering with us to achieve this have learned how to do through social media, Facebook and other things. And with the further evolution of this, we now have ambient listening of the clinical encounters, where we have devices that are capturing what's happening in the visit and creating notes that try to alleviate the workload of the clinicians. We have, if a patient sends me a note, there is now a first draft of my response that is produced by artificial intelligence. And companies are evolving that provide a digital-first healthcare. So it's not like you see a patient first face-to-face and you can follow up digitally. No, these will be all digital or digital-first companies. There is the idea that we need now data integration, so not only your health record, but also your Amazon shopping list and your Netflix viewing history and other things integrated, so we have a better sense of who you are and what your behavior is. And we can begin to do something more with that through AI bots or other mechanisms, where we now can change your behavior. And the same companies that are now playing with us in this field learn to change our behavior, for instance, our political behavior, through integration with Cambridge Analytica and other companies that have created an environment where conversations, democratic deliberation, and polarization, those are impossible, and polarization has become the rule. But those people, those same organizations, those same companies are now in healthcare. And so in this evolution, we started with healthcare. We've seen the technology come into healthcare, but now we have a different entity, health tech, that is now intent on delivering care directly to its users through the use of technology without involving the healthcare system that you are, some of you are hoping to join and manage. It's moving from healthcare with people to healthcare done to people. In 2018, Eric Schmidt, who was the CEO of Google, was also on the board of the Mayo Clinic, said this statement that most hospitals should put on the cloud all their data. It was a little self-serving, right? I mean, because Google can handle that. And they put all their data on the cloud so that they can learn and they can do predictions about who needs to be hospitalized, who needs to be sent home early, and do all sorts of activities that will enable us a better healthcare system, more efficient and more effective. And Schmidt said healthcare is becoming an information science. That the problems of care really are not problems of information, are problems of data. Well, this has become much more a belief that's more disseminated in the sort of Silicon Tower sort of version of healthcare, not the ivory tower represented by institutions like the university, but the Silicon Tower, which now seems to be running the place. And Vijay Pandey is a part of a group that invests significant amount of money in startups. And when you can put $100 million in a startup, you're beginning to define the field. And in a podcast in January of last year, he said, I think about what a primary care physician has to do. They ingest all this data and make a diagnosis and then send the patient to a specialist. That's literally a data science problem. That's literally not what a primary care clinician does, right? But by doing the switcheroo, by changing the nature of the problem of care into a problem of information and data, they are setting the stage for make sure that who is in charge of your health and your healthcare will be the same people that are in charge of your Facebook account and your Instagram. So what are these? What's happening with the qualities of care in this evolution? I started by saying that I think we're in industrialized healthcare, where care is fragmented, is transactional, is hurried, burdensome, generic, and sometimes cruel. Where care can be depersonalized and depersonalizing. It just feels like you're being processed through. The next evolution is here now, which I believe is data-fied healthcare. In data-fied healthcare, the obsession is with biological precision. We gotta know everything about you. And we want all your data, and we want to integrate all your data so we can predict what you're gonna do and manage that behavior so that you can achieve the goals that we are getting paid to solve. But the cost of that is biographical indifference. We don't care who you are. And so medicine becomes a field that is hungry, greedy for more data, and is no longer solving problems of care, but solving problems of information. So it's not only now that you are depersonalized, but actually the human being that is showing up is irrelevant. It's just a source of data. And the next step is artificial healthcare, in which you have sensors and systems that are constantly observing the data you're producing for anomalies, and then activating this remote behavioral actuation to change your behavior in the real world so that those data can go back to whatever norms are established by someone. No longer the need for clinicians to examine you or get to meet you or have a conversation. That's friction, because it means two humans talking that we can control. And you don't have to show up, because we'll know how your health is, because we'll have sensors in your toilet and in your fork and on your phone. We already have that. And the care becomes disembodied. So there's another response to this problem of healthcare that doesn't require us to go in this direction. And the other response is to think of it as a crisis of care in and of itself, which requires us to focus on what care is. And here is my moment of pride. Because it's easy for me to talk, oh, care is this, care is that, and care is whatever. But we are here. You are here. We're still here. And we have seen this community demonstrate to the world what care is really about. I travel a lot, and people are, upset about what they're seeing in Minnesota, but they very quickly go, but the response, the ability to so quickly mobilize mutual aid, to care for and about each other, is something that is making people appreciate what humanity is able to do under severe distress. An emeritus faculty of the University of Minnesota, John Tronto, formulated with Fisher a definition of care that describes this. Care is everything we do to maintain, repair, and improve our world so we can live better in it. And those of you who have chosen to pursue a profession in health administration, you're joining the professional version, the specialized version of that commitment to care that this community has demonstrated the world. Could be a response to aggression and violence. Most psychologists will say, well, it's a fight and flight response. But this community has demonstrated that tend and befriend can also be a response to stress. And Dr. Tronto also formulated care as a moral disposition and a practice of noticing and responding. Noticing, which requires us to pay attention to what's going on, to be present, to understand the situation in high definition, not only again in its needs, but also in its strengths. And it's not enough to go, oh, this is bad. But you have to then decide, which again we've seen here, you have to then decide to do something about it. To do something about it. And that decision to respond is what creates hope. Because the situation can only be made better in here because we've decided that we're going to do something about it to change it. And so that possibility of inventing action creates the possibility to improve the situation that gives people hope. Care is also caregiving and care receiving. And caregiving is something we do with people, mobilizing competence and compassion. And care receiving is when we know we've done it right, because the recipient of care is the only one in a capacity to say, was this care pertinent, adequate, and desirable? So care is a moral disposition and a practice, is noticing and responding, is caregiving and care receiving. Now, how do we make sure that our healthcare system can do care? I mean, it's supposed to be its core function. Well, the first thing is we have to cultivate that care. We have to make sure that we acknowledge that care is healthcare's core purpose, core function. Many healthcare organizations have forgotten that that is what they're there for. I mean, a joke of one of my colleagues is that healthcare will be completely fixed if patients stop showing up, right? But to what end, right? I mean, in boardrooms, at the leadership level, we need to make sure that the business language doesn't obscure the language of care, that we understand our problems of care with the language of care, and that when we are trying to motivate action, we tell stories of care and use those stories to drive change. Oftentimes, stories are shared, but the stories that are shared are stories of marvelous achievements in cure. It's the stories of care that are really driving the opportunity to humanize that healthcare. So cultivating care is one option. Think about these old quotes and what they were telling us about the primacy of care. At the Mayo Clinic, William Mayo, the patient's best interest is the only interest to be considered. It's part of the statement of governance. Statement of quality, Venice non obedient. Towards the end of his life, he happened to also be a poet, so that helped. But he says, ultimately, the secret of quality is love. This is the quality dude. You think in dashboards and numbers and stuff like that. He's talking about love. Graph that. And then John Berger, who was an art critic and writer from the UK, he said, I stopped trusting clinicians when they stopped loving patients. Professionalism. We need to eradicate cruelty from healthcare. It doesn't have a rule. If you are in charge of an organization, make sure that cruelty, any evidence of it, is a never event. And it doesn't happen, and it gets extirpated very quickly. And then, and here's my invitation to all of you, and then we get to reinvent the work of healthcare. And so, right now we live in a healthcare that is so proud of its ability to know and ability to do. But we need to be proud of our ability to care. And I hope that I make the case for you that it's a bit different. Where people are subjects of study, we understand their biology very well, or sources of raw data. But we need to recognize that the substance of our work is living, is people living. It's incredibly precious work. And we get to work with this, with people living. We need to go from this obsession with precision and prediction and algorithmic perfection and to live in the world of living, which is a world of ambiguity and uncertainty. And how might we do that? I think we need to invent something completely new. We need to invent artisanal healthcare. And we need to invent artisanal healthcare at scale. How the heck are we going to do that? We have a problem in our heads, which is that for some reason, the future is only to be answered with technology. But what other ways of imagining the future can we muster to face this challenge, how to fix the problems of care that we have? In artisanal healthcare, it's going to be a relationship-based approach. We're going to be caring with people. How do we do it at scale? How do we do it with equity? Where we're going to develop this incredible expertise, and yet our starting position should be, I do not know. Because that starting position creates in our frontline folks the idea of curiosity, of asking the question, who are you and why are you here? And be fascinated by the living that this person is trusting us with when we do the care. And that means that we are going to be dealing with ambiguity and uncertainty, not with more data. Data is going to be helpful, but not with more data. But we're going to have to deal with stories. Stories that help us make sense of what's going on. Stories that make our solutions sensible in this situation. Stories that are not this universal, evidence, which we're going to be using this evidence to formulate plans of care, but we're going to be looking for what's particular about this patient. What's from here and now for them. Not caring for people like Maria Luisa, caring for Maria Luisa. I put one chair in that previous slide, and that's because Gregorio Marañón, who was an internist in Spain at the beginning of last century, was asked, what's the most important tool of a clinician? And he said, it's the chair. Because that is where we slow things down and we get to listen to people. I would put forward that today, the most important innovation in healthcare is the unhurried conversation. Is the unhurried conversation between clinician and patient? Is the unhurried conversation between caregiver and patient? Is the unhurried conversation between clinicians? Is the unhurried conversation between leaders and administrators and clinicians and the whole community? It's one of the challenges that we have to be able to move forward with care is we don't get to have unhurried conversations. But when we do, it feels like magic. Because the world is accelerated and it's confusing. And when it's confusing, we cannot exert our own will. And in those unhurried conversations, we'll do the magic trick of healthcare, which is to take patients that show up with an undesirable situation that we get to understand in high definition, and we get to co-produce, we get to co-create a plan of care. We get to craft a plan of care for patients that actually fits each person and makes their situation improved. That difference from undesirable to improved is the reason we show up to work, is to make that difference. And the way to assess if healthcare actually did something is to ask this question, did it make a difference, a positive difference in the life of the people that have trusted us with their living? There's a manifesto that was written by a number of people from all sorts of walks of life in Europe, and it has this paragraph that I think describes very nicely what I'm trying to convey for you today. If you can create a healthcare system that enables this, we're making progress. Patients and clinicians collaborating in designing care plans that maximally respond to each patient's unique situation and priorities while minimally disrupting their lives and loves. While minimally disrupting their lives and loves. While minimally disrupting their lives and loves. Because to care is fundamentally human. Everyone in this room is here because someone at a critical moment decided to care for you. And unfortunately, the mission is infinite and the capacity is not. And so we're always going to have this problem of care. And we need to think about where we allocate our resources. Right now, we have decided that most forms of suffering must be responded with professional healthcare. And there's just no way we're going to ever have enough healthcare to respond to all forms of suffering. We have abandoned two really powerful ways to actually address this. One is public health. We have abandoned public health as a fundamental preventive response, as a way of actually elevating people's ability to flourish by eliminating environmental and both environmental planetary but also environmental social factors that reduce the people's capacity to flourish and to meet whatever potential they have. We need to reinvest in public health, but public health not in the military version of public health, the democratic version of public health, which requires unhurried conversations in communities where people can express their opinion and hear someone else's opinion and come to a consensus. Have you heard of that? It's lovely when it happens, right? It's called democracy, right? It's not about the voting bit. The voting bit is just the one thing we do, but democracy is that conversation. We need the democratic deliberations to form locally sensible public health responses where real prevention happens. What we've done is we've actually transferred prevention to primary care and completely overwhelmed a limited system with a bunch of healthy people that we've turned into patients, and we don't have any capacity to care for the sick people anymore. And the other one is common care. We've de-skilled grandma. When a young mother in the middle of the night with a kid screaming all night long called her mother and said, "Mom, this kid cannot stop crying." Mom will say, "Oh, take some brandy and put it on the gums of the kid and the kid will be all right." Today, a young mother calls her mother and said, "The kid is not stopping crying, he's crying all night long." And the mother goes, "Oh my goodness, it could be an inborn metabolic error of metabolism. Need to take him to the emergency room right away because you don't want to be..." And we've totally just killed grandma. So we need to find a way with all the technology, all the internet, all the AI, all these things, all the YouTube videos, we have to be able to actually have fundamental self-care and mutual care skills that would allow for most of the responses to occur in the community. We need to be proud of our care capabilities, like we're proud of our cooking. We have cooking shows, cooking books. You can go to stores and buy cooking utensils for almost any meal that you can prepare. And it's a form of care that has got elevated because now guys get paid a lot for that form of care, chefs, right? And there's shows on TV for that. And so it cannot be that the two forms of care that we've been able to disseminate are resuscitating somebody who's dead in the middle of the street with CPR or fixing a meal. There's a whole range of other skills that people can pick up and do very proficiently. But we have to invest in this common care skill that elevates that. And we need to make sure that when we do that, we do not take all that work and put it on the shoulders of women. Most of the caring is actually delegated to women across the world. Increasingly in the Northern Hemisphere, the women that are being asked to do this work are women of color and immigrants. One of the crises of actually prosecuting immigrants now is the crisis of care that is creating because many caregivers are women. I can't quote this, but I understand that if you look at the health professionals that died during COVID, the majority of the nurses that died during COVID were Filipino in the United States. When we advance common care, we have to make sure that we do it democratically, so that if you expect to receive care when you need it, then you have an obligation to care. And I don't care what sex or gender you have. That is an inherent obligation of being a human and a participant in society. And then when we have this shrinking, hopefully, professional healthcare, we need to make it humanly sustainable. We need to make sure that those who are showing up to care are well-resourced, and they're well, and they are competent, and they can do a good job, that they have conditions of care that are favorable to that. They feel valued. They can work in teams. They're not working in hurried and chaotic environments. This is work from my colleague, Mark Linzer, that when we bring technologies into their space, not only that we do a financial impact analysis to see what will be the effect on cost, but we do a care impact analysis. How is this going to affect our ability to care for people and respond to their needs? And that we make sure that the care is minimally disruptive to our patients, but also minimally disruptive to our clinicians. Because one thing we have to remember is that when we don't exploit a commons until it's exhausted, it's a renewable resource, and care is a renewable resource when it's not exploited. We all remember this moment. The man that fought for his life in the ICU, and after weeks or months, eventually gets to go home. And all the clinicians lining up on the way out. You can see their emotion, you can see their satisfaction, their happiness. You don't need to survey these people to know they're proud of what they've been able to do. And that patience, the smile, emotion that you can see in his eyes. Care, when it's not exploited, is a renewable resource. That's the precious activity that we have. Let me finish up by saying, yeah, but we have AI. So that's all very nice, but we have AI. So we have to be very careful. Do we understand what care is and what it means to people? Do we know that before we go ahead and replace all that with AI? Do you know what it does to mattering? When I get to show up as a patient and I have a clinician who puts in aside and then listens to what my problem is and decides to put attention and technology and compassion and mobilize that for me, I recognize that I am a valued person, that I matter. And when my clinician can do that, they know that their expertise and their effort and their work is valuable because they can make a difference in my life, that they matter. Care is the activity in which we have the mattering of people. So are we ready to give that up so that AI can do it more efficiently? And then are we going to do it in an equitable way? Or is it going to be like the executive health program? It will be in person and everybody else gets a digital. And I think it's helpful to think about the late Paul Farmer when he said that the idea that some lives matter less is the root of all that is wrong in the world. And I know these are difficult problems, but we need to exercise our imagination. Read poetry, read fiction, expand your brains. The solution to most things cannot just be more technology. Human problems are complicated, and I'm paraphrasing here. If you think technology can solve your problems of care, you don't understand technology, and you don't understand your problems of care. And if we're going to have this technology, we need to make sure that we govern that technology, that we make sure that it is there to help the humans care better. But then we bump into the same problem, which I'll describe in a minute. When we think about this figure again, it's possible that if we can govern the AI, we can find excellent ways in which robotics and autonomous tools can make that cure side perfect. And the other side, we might be able to have systems that augment the skill of the clinician in figuring out what to do. But that requires that the values that guide the implementation are the values of care. And I think it's helpful to remember the words of the Nobel Prize winners, Simoglu and Johnson, where when they look at hundreds of years of progress and technologies coming into society, they notice this, that there's nothing automatic about new technologies bringing widespread prosperity. Whether they do or not is an economic, social, and political choice. So who gets to choose? And who determines who gets to choose? Coming back to the fact that we need to take back our democracy. We need to take back our power, because this will be chosen for us, and we may not like what we see. I know that I've painted a picture that perhaps feels utopic. Galeano from Uruguay tells a story of a student asking a teacher, "Why do we need utopias?" After a few minutes, the teacher responds, "We need utopias because it's like the horizon. Utopias are like the horizon. If you take 2 steps towards the horizon takes 2 steps back. If you take 10 steps towards the horizon takes steps back. If you take 100 steps to the horizon takes 100 steps back." So that's what we need utopias, to walk, to get walking. And so we just have to know in what direction we want to go. And my invitation to you is the direction in which we should walk together is to invent the other future of care. A future of care in which we recognize and honor this idea that to care is human, and that we achieve for ourselves and for the generations that follow us careful and kind care for all. Thank you very much for your attention. I think we have a few minutes for comments or questions. I know there are 2 microphones that are going to be going around. There's one over there and another one behind you over there.
Hi, my name is Cody. I'm a second-year MHA student. Thank you for being here. My question is pertaining to healthcare systems and organizations that are both struggling with their bottom line, but those that are not struggling with their bottom line. How can they balance the two between care and cure?
Yeah, I think your question refers to the fact that many organizations look at their portfolio of services and identify some services that are losers and some services that actually contribute to that bottom line. And they will favor those services, closing out services that perhaps are not good, are not as financially beneficial. We've seen a lot of obstetrics and gynecology services disappear. We've seen pediatric emergency rooms get shut down on the basis of those equations. In my home country of Peru, I was once interacting with a for-profit healthcare system there, and the CEO basically said, well, we need to shut down that emergency room because the per-ticket money is too little, referring to a pediatric emergency room. I don't know how I don't know how the leadership of healthcare systems needs to do that balance. I think it's impossible under some of the policy context in which they have to operate. I think it's very challenging that most of the healthcare that is funded through employee benefits, that employers are allocating to large insurer organizations to then invest in providing the best possible healthcare, ends up being supportive of returns to investors rather than to improvement and sustaining of those services. So we have this thing that I think is fairly obscene. I would be curious to know if there's some experts in the room that can probably use more technical terms than obscene. But when you actually give a lot of money that is part of people's compensation, and instead of, for the purpose of actually supporting health services that people need, that the companies that receive the money satisfy that contract by reducing the cost for the employer and by improving their bottom line and the compensation of their executives, and let the hospitals and delivery systems that ought to be supported by that fall apart and be unable to provide services, and force the kind of decision that prevents those leaders from being visionary, meet the needs of their community, and do so in relation to the proportion and the need of that community. To close a pediatric emergency room, to close a birthing center and all these other things, is basically telling that community that there is no investment in its future. And so you'll have young people leave that community, and eventually that community cannot support the hospital eventually will close. And so it's not like, okay, how do you do it? I mean, it's impossible in many cases to do it under the current policy structure. And I think it requires us to be active at every level. So we need to invent new models of care, yes. We need to understand across all the diversity that we see where might be the bright spots that might be worth imitating. But we also need to work at changing the way our policymakers are making policy. Who is influencing their choices? And can those choices be influenced just by money, or can they influence also by bright ideas? And where can these bright ideas, for instance, the ideas that are born out of the university, how can they make their way to policy? And I think there are very good examples in this department of ideas that have come from the research and have been able to influence policy. We just need more of it. And we just need to have campaign finance reform and other strategies to prevent big money to actually run Congress and run policy. So it's not a simple, oh, you should do this different or that different. We need a holistic view of the system to actually be able to make the system care, which is why I describe this as a utopia, but not as a utopia that should force you into complacency and to give up, but one that should stimulate your creativity and your appetite to be politically engaged and active. The kind of political engagement and activity that everything is telling you to not do. How's that for a non-answer? There's another question over there, hopefully an easier one.
Hi, I'm Kelly. I'm an undergraduate here at the school with the HSM program, and I was just wondering, you showed that picture of people putting out their shoes because they're so tired of waiting. You talk about the emergency department and a woman who, it's a hypothetical situation, but it's all too real for too many people that they can't get the care they need in time. The system is flooded with these patients, and I think the main thing you said is public health. Do you think public health is the answer? Because you also talked about unhurried conversations. So how do you balance the long waits and the massive amounts of patients with the fact that unhurried conversations is really going to be what's helping people?
Yeah, I think what we need is systemic thinking, right? I did not say it's the answer, right? In fact, I've almost tried to be very careful to say that there is no answer. We need to think systemically about what I've described. So I don't think that we can fix healthcare without also fixing public health and increasing the investment in there. Because it is a primary care clinician needs 27 and a half hours per day to do everything that is expected of them to do. Of those 27 and a half hours, the majority of it, I think it's like 14, 15 hours, are dedicated to prevention. That should be happening at the level of public health. I was telling somebody earlier, I have a colleague that in Tumbes, in the north of Peru, did a randomized trial where people got marketed potassium salt rather than their usual sodium chloride salt. And that potassium salt is healthier from a blood pressure perspective. But mobilized all sorts of marketing and other things, make the packages nice, had the chefs in town use it and tell people that they were using it and so forth. And the consumption of that kind of salt displaced the consumption of the other kind of salt. And they were able to measure a reduction in several millimeters of mercury that correlate with a reduction in strokes in the region, without having to have every single person line up to see primary care, get their blood pressure checked. Oh, it's a little high, come back next week to see if it's still high. Oh, it's still high, let me give you a pill. Now in a week, let's make sure your potassium and your creatinine to make sure that the pill is not causing harm. Now you have a full-time patient. All of that volume of work avoided by, for instance, doing a manipulation on the salt. Think about all the heart attacks we don't see now because we can't smoke in here. So I'm not saying the solution is public health, but man, we got to do more in public health to try to actually not overwhelm primary care with all the prevention tasks that otherwise nobody else is doing. So it's about moving the work to the places where it should be. We're asking healthcare systems to go upstream, to do population health, to do prevention one person at a time in their capture area. That is incredibly wasteful of a limited resource, which is primary care, and incredibly expensive per capita. Why are we doing that? Because we don't have a public health system. And so it's not the solution, it's part of it. If we can build that up, if we can build self-care and mutual care skills, you know, we might be able to then make sure that we have a sick care system that actually can take care of the sick in a way that is careful and kind. That's sort of the proposal. But it's there not to be right, it's there to stimulate reflection and innovation and new thinking about it, not simply to rearrange a payment model or a model of care without fundamentally changing the system. Yes? You guys are not looking good. All the questions are coming from this side. I don't know what stories.
My name is Steve. I'm a MHA program faculty member, and I really appreciated your messaging around compassionate human care, kind of messaging, super inspirational. But it felt like perhaps a little bit of a bias as part of that against modern technologies and data and the like, and I'm wondering if that's really your feeling or whether maybe there's some synergy opportunities where modern technology and so forth and some of these tools can actually enhance the human care, if those can kind of work together in the end. I was just wondering if you could comment or elaborate on that.
Yeah. In my first slide, I put care unit and parentheses, care and AI lab, right? So I want to highlight that point. I appreciate the opportunity to clarify. I'm very enthusiastic about technology. The question is, who is determining how we use it? What are the capabilities? What are the safeguards? How are we handling privacy issues? How are we preventing this, for instance, recommender system? You know, there's been an enormous amount of work, methodological work, to actually improve the quality of guidelines, right? And there's a lot of work to manage conflicts of interest and formulate reproducible approaches and help people decide if they can trust a guideline or not. Today, in my clinic, I go to a system called Open Evidence, where it's an AI black box, and I put a question, and there comes an answer with a recommendation. All that evidence-based medicine methodological work that went into this designing guidelines that will be trustworthy And 40–50% of clinicians, according to their advertisement, are using a system that's completely impenetrable as to how it's producing its things. It has references, but we know that references, many of them are imagined and are not real. But they're, but what about all that work that was put into figuring out how to do recommendations properly? So I'm not against technology, but these technologists believe in the minimal viable product. I'm going to produce something and put it out there and getting the investors to come in. I'm going to develop the next unicorn. It's going to be $1 billion. That's a different mindset than the mindset where you are with your patient and you're trying to figure out how you're going to make the situation of this person better. That difference in mindset calls for us to be much more involved in the governance of the development, design, and deployment of those systems, rather than have completely given up on control and just let Microsoft and Google and who knows, OpenAI and all these people decide what ought to be in our offices in the clinic, what ought to be in people's phones in front of you to ask health questions and guide their behavior. I mean, we saw in the Super Bowl the advertisement for PSA testing, right? Oh, everybody should get PSA testing. I mean, we know that's not the right answer to that question. But now it's advertised. Now primary care clinicians are going to have to deal with a bunch of healthy people who have much other health problems. They're overweight, they're smoke, I don't know what else, but they're coming in for their PSA. Right? So I don't have anything against technology. I have everything against the technology being governed under a set of values and rules that are different from the ones that we think we have in healthcare. I'm going to put it a little more aggressively. Many of the gurus of these companies are on the record as being transhumans. What they mean by that is that they don't care about the well-being of people on the planet now, because there will be so many more people in the future that if we let technology just solve all our problems, regardless of the cost of it today, the people in the future will be better off. How is that consistent with the ethos of healthcare? But we're letting those people be in our offices. We are inviting them to our system. We want them to be our partners. Their logic and their philosophy is anti-human. And so I'm not anti-technology. I just want the technology to be in the hands of people who hold similar ethical values as those assumed by those who show up to care and those who show up to receive care. So I appreciate the opportunity to clarify. Yes?
So, touching a little bit on your subject, Luke Hommel, I'm entering my second year of alumnihood from the MHA program. On the front line, the ambient listening has been awesome. I get to put my phone on the counter and I just start asking questions and looking at a patient. Great. I can let somebody else type all the stuff. I was typing more than a novelist every day. And so that was hours of my day. That was just nonfiction writing. But the ambient listening lets me interact with the patient and let that happen. And that's an amazing application. It's not perfect, but often it's good enough.
I use it in almost all my encounters.
Yeah. Our EHRs, besides becoming more of a cash register or logistics machine, think of an airline cockpit now with all the digital displays and everything kind of consolidated, simplified. We took healthcare from a place where it was simple on the interaction, and we turned it into an analog cockpit that has 100 dials all over the place that you're supposed to pay attention to at all times. That's all on the EHR. There are so many inputs to the human that you can't process and manage all of that accurately within an encounter, and then you just start selectively ignoring pieces of it so that you can get your task saturation down to a manageable level. Where I would encourage any of you future innovators is when you think about applying the technology into healthcare, it's how do you make the healthcare simpler, the delivery simpler. Let the humans do it, but let the EHR just do all the data stuff, but don't complicate our job.
Yeah, that's what I meant by minimally disruptive for the clinician, right? I think the job is hard enough as it is, and a lot of our tools do some job, often do multiple jobs, because there are multiple people that are interested in what you're putting in that fiction that you're writing, or hopefully nonfiction that you write, which actually is probably not your colleagues, and it's probably, rarely is the patient. Almost nobody's reading any of these notes that we're producing in large volumes of. With the ambience listening, there's something really interesting happening. There are two logics of communication, the slow logic and the fast logic. The fast logic of communication is the transaction at the McDonald's counter. What do you want? I want a burger. What do you want it with? I want it with fries. $10, end of story, right? Transaction. That's fast communication design. In fact, if you make that slow, oh, how is your day? How are you doing? How's the weather outside? There's a line that gets upset. This is fast food, man. What are you doing, right? So that is designed to be fast communication. The clinical encounter is supposed to be designed to be slow communication. But because of the pressures of time, a lot of the conversations in clinical encounter have become a little bit more transactional. And so one of the things that the ambient thing is doing, which is actually really interesting, is all of that sort of, stuff that you will transactionally try to extract, we're now changing our communication strategy because we know that the thing is listening and it's going to capture it. And we can just have a conversation, and those details are eventually going to be captured and going to be documented. So we are reclaiming, through that technology, we're reclaiming a slow communication design that is designed to develop relationships to be not transactional but transcendental. When you look at the randomized trials, they're only measuring time spent, and the difference is tiny. So very soon, healthcare organizations are going to go, I don't think I see that much efficiency. But you and I know that it's changing the way we're interacting with people. We're abandoning the transactional Q&A, which leads to the interruptions and the hurry, and we're going to this more open-ended conversation where we're developing the relationship, understanding, expressing emotion, and capturing what needs to be done and figuring out with the patient what to do. We're having those unhurried conversations enabled by some of the technology that we were discussing before. But it's interesting, in the randomized trials, if we have the sort of efficiency mind frame, it's going to be pretty hard to continue to say we're going to pay for that because it's saving us a tremendous amount of time. We can see more patients. We're actually changing the way we're communicating, and the efficiency in terms of time is actually changing too little for many organizations to value it. So that's why competitors of some of the initial technologies are now saying, by capturing more data points, you can build more for that same visit. And now we're seeing in front of our eyes a tool that enables us to have a slow communication stuff or transcendental communication being used to actually accelerate and improve building. We've seen this show before, right? And we have to be very, very careful. Who is in charge of these technologies? What motivates their application and use? And can we just do things for the right reasons? I hope so. Anybody from here? I mean, this is just sad. Did you eat something different? I don't know. Not enough vegetables.
All right. So I think one thing you alluded to a little bit throughout your presentation, a lot of the guardrails that are...
Introduce yourself to the group so
fair enough.
that you become
Hello,
famous.
Everyone.
Yeah.
Some of you know me well. I'm Josh, first-year MHA student here. So a lot of the things that you mentioned that maybe constrain the ability in this relationship between clinicians and the people they're providing care for, not necessarily within the control of a given health system. You mentioned EHRs being legally required, there are documentation standards, insurers have kind of their hand in the mix. Given that some of these decisions lie outside the purview of what an individual system can do, what sort of interventions do you think they can take to try to maybe push things in a better direction?
Yeah, so we have, I'm going to talk a little bit about the patient revolution work. So for instance, one of the activities that we do in that organization is we get boards of hospitals to come together and discuss how care participates in the decision-making at the board level of hospitals. So that's still within the healthcare system, right? Within a particular healthcare system. And it's actually quite striking to hear board members say, well, we never discuss care. It's not on the agenda. You know, when we were in a large healthcare system, and the head of the quality committee of the board goes, my job is to look for compliance so that we can get the 5-star Medicare rating on the quality stuff. I don't look at care. This is why most healthcare organizations were completely blindsided by burnout. They were not monitoring the conditions in which their clinicians were taking care of patients. They were not monitoring the wellness of their own workforce. So there are a lot of things, even though there are many things that are out of control, there are a lot of things that leaders can do, from the board, CEOs, all the way down, to set up, basically to say, look, this organization is about care. We know that care is not happening, automatically. It happens between people. We're going to take care of people that we're going to put in front of patients. We're going to make sure that they're well. We're going to make sure that they're competent. We're going to make sure that they have the conditions they need to care well. Patients come over here, help us make this better. Let's co-produce a healthcare that meets your needs in your community. There's a lot that we can do with that. But it's very, very hard under the current conditions to do it. I recognize that, and I think that's why it cannot just be done one healthcare system at a time. Right? You will never get there, right? And that's why we need to have that. You need to have very good, different kind of leadership in healthcare that understands that care is the core purpose of healthcare. This is the reason you could all be bankers, right? But no, you decided that this is, there's a little bit more like, human value in managing a core investment in our mutual flourishing in healthcare, right? This is why you're doing this stuff. Right? And so I think we can do a lot within our healthcare systems to do that. It's just that we cannot expect healthcare systems to solve it one healthcare system at a time. That is part of the solution. Again, like before, I don't think it's just the one solution. We have about 130 Patient Revolution Fellows across the world. When they finish their Foundations of Careful and Kind Care, they go on to do a capstone project. Many of those projects are small changes in their own environment that begin to demonstrate something different. When you look at how you get to change the world, one of my favorite models that is nonviolent is the invasive species on a pond. Right? So if you're in a pond and you show up with an invasive species, eventually you're going to displace the old one. And I suspect that we can do this. I suspect that we can actually bring examples, and you can share it among yourself. Look, I'm doing this in my center. I'm doing this other thing. And we can learn like a bunch of ripples creating a wave of change in which you displace the old ways of doing things because you're using a different logic. You're using the logic of care, not the logic of business. You're thinking of healthcare as an investment that demonstrates our solidarity, not our capacity for greed. And again, to say this here, at this moment, when you see your community teaching you that every day, people giving up not only of their own time, but also their own lives for the well-being of their neighbors. This is not poetry. This is reality, and it's happening outside of those doors. Can we not pay attention and learn from that? Can we not be inspired by our own actions? So, this is one of those things that you say, oh, that's really nice. But it's happening. And it happened before. It happened during the pandemic. The whole world's economic activity stopped. Animals returned to cities. You remember those animals that were, they were like, what the hell? This is the rhinoceros in the middle of, So if we can stop all economic activity just to take care of ourselves, we've done it. It's not like a story. We've lived it. You remember it. Right? And so, but we forgot. We forgot real quick. We're going to forget this. But I think part of our responsibility as professionals is to hold on to that and say, we learned that. Let's use it. So no, I don't think we have to rely on individual health organizations to show us the way. I think we need to learn from each other. We need to develop caring and learning health systems that every time they learn a new way of doing things and doing it better, they disseminate that, they share with other people, and we learn together and we do it better. But we also need to recognize that that's going to be limited by who runs the policy, who controls the technology. And that's where we also need our democratic muscle to come back. That's where we also need our public health to get stronger. That's where we need to disseminate the capacities for common care. It's that whole picture that I think we need to move towards. Yes, go ahead. Question over here.
Good evening. My name is Anita Tamang. I am MPH AP first year. So I have some thoughts, but I don't know if it's going to be a question or not. So I have been here for a few years and still learning about healthcare system. My question is around the care. So based on my observation and lived experiences in this country, healthcare system here so far, it feels like there is a gap in care. So everything you mentioned about care, right, like eradicating cruelty from healthcare system and also not industrializing healthcare and Paul Farmer, all that mission, everything, I agree. That's what my heart speaks. And also, I work as community health coordinator in refugee health promotion and have experience, like on-ground experiences, you know. So seeing everything and all of my experiences, even without having artificial intelligence, like any technology, what I feel is that it has always been like there has always been like gap in care. So, for example, in the healthcare system, there is whole like system that is based on like profit making, and there are and then doers, right, like clinicians and people who are actually like people who actually do and have so much care and have so much love to give to patients, but those people who have that care and love are managed by people who might not have that much care. They, their whole like mission might be built based on profit. Just like, you know, like how do you close that gap? Like this whole system that's placed, that's controlling these doers who has so much love and care, but the system doesn't really care about like how much love and care you have to give.
I can answer that. So
Thank you.
Thank you for your question. I think I've been to a number of different places and I've talked to a number of different audiences. When I talk to groups of patients, they go, that's all very nice, but my doctors, you know, they have the power. I can't do anything. When I talk to groups of doctors, the doctors go, oh man, I mean, it would be lovely if you can bring about that you're talking about, but my administrators, man, they won't let us. I had the opportunity to talk to a room full of CEOs in Copenhagen. They were all the CEOs of all the hospitals in Denmark. And to my surprise, I finished talking and they go, man, that sounds really, really good, but man, you should talk to our politicians. You know, they are. Like, nobody seems to have agency in healthcare to make a difference, right? So I think the first step is to recognize that we have a lot more power than we think we have. Right? If patients stop showing up to a hospital, that's going to be a disaster. If clinicians, nurses, doctors stop showing up to work, that's going to be a disaster. We have tremendous amount of power. The problem is that the same sort of psychology that makes us think of health problems as problems of individuals' fault is also asking of us to think, what can I do to solve this problem? Which is a mistake. We can't do anything. The question is wrong. The question is, what can we do to solve that problem? And one of the things we have to avoid is to make sure that we find someone else to blame. You just said, oh, the managers don't love, and like, you're in a room with a bunch of them, right? And I don't know if you noticed. And I would put forward, I mean, I discovered this at a class that Ryan Armbruster invited me to give, where I show up and I'm starting to talk, and I started to listen to the students, and these students are going into healthcare for the exact same reason I went into healthcare. The exact same reason our nurses have gone into healthcare. Everybody's going into healthcare to try to make a difference in people's lives. So I think we have to push back against the idea that because that's what they're being held accountable, because that's what appears to be the thing that is driving them, that really is the reason they actually are there to do that job. You know, and so I think we are much better off thinking, man, we are in this crisis of care together. How can we use the power that we have to make a difference? Well, Dr. Wild is standing up, so that's my indication that the time for questions. Thank you again very much for your attention.
Dr. Montori, thank you so much for that, wow, exciting, inspiring talk. Let's see what our MHA program alumni and students will do with what happens next. I'm Katie White. I'm an associate professor here in the School of Public Health Division of Health Policy and Management, and the former MHA, past MHA program director, and delighted to be here with Victor Montori as our visiting professor, because I've been working on coordinating this over the last year with David J. Fine. And so it's just so wonderful to have this all come together. So on behalf of the MHA program and the School of Public Health, I want to thank you, Dr. Montori, for this wonderfully inspiring lecture. We thank you for accepting our invitation to join us as this year's David J. Fine visiting professor. We appreciate the opportunity we've had to learn from you across 3 days of events. He was here in January with our executive students, and then here in February, 2 consecutive days, including today's public lecture, tomorrow's division research seminar, and a very exciting panel discussion that Bjorn also mentioned, What the World Needs Now, Care as a Vision, Resistance, and Hope. And you all have a little bit of more glimmer on what that discussion will be about tomorrow. There is a QR code on your table if you would like to join us. We're still taking registrations, or you can walk in tomorrow at 3 p.m. at Kaufman Union Theater, so please come and join us. Dr. Montori, we also appreciate the many one-on-one group sessions that you are having with students and faculty while you are here. I said to him, we want to embed you in our program and here in our school, and so you are one of us, so we're glad you are with us. So as this year's David J. Fine professor, we want to present you with a gift, which I brought up, and I was afraid to take it out of the box here. But I'm going to take it out of the box because I want to show the audience, and especially David J. Fine, who will see this in the recording. So this is a lovely crystal piece, as you can see, and it says School of Public Health, University of Minnesota, Master of Healthcare Administration program. The 2026 Dr. David J. Fine Distinguished Visiting Professor in Healthcare Administration, Victor M. Montori, MD, MS, in great appreciation, and I hope you enjoy this for your... You can put it right back in the box. So before we close, I want to thank the planning committee for selecting Dr. Victor Montori and all of those who've been involved in helping to ensure that this program is a success. To the audience, thank you for joining us tonight. We look forward to seeing you at future events. Thank you for being here, and have a good evening. Thank you.